are moving to the next item of our agenda, which is item 5D. Can people afford to pay for health care? New evidence on financial protection in Europe. The relevant document is Euro/RC68, information document /1. This is a critical discussion and thoroughly on top of the agenda of all the ministers of health. So let me, without any further ado, invite Dr. Tomasz Evetovic, head of the WHO Barcelona office and on health systems, and his colleague, Dr. Sarah Thompson, senior health financing specialist, to briefly introduce the topic. Please, Tomasz, you have the floor.
Thank you, Mr. Chair, ladies and gentlemen. I'm honored to have the opportunity to give you an introduction to this session on financial protection in the European region. This is a product of 5 years of work with over 50 national and international experts covering 25 countries and using a new methodology that is relevant to all member states. Can people afford to pay for healthcare in Europe? Some can, others cannot. What we need to know is who those people are who cannot afford to pay, for what services, and why. The new evidence on financial protection suggests that far too many people in our region have insufficient protection against the cost of using healthcare. Everybody needs an umbrella, a strong and well-functioning umbrella that provides protection on rainy days. When people are excluded from coverage or have weak umbrellas that do not cover the services they need or the cost of using those services, we see gaps in coverage. Gaps in coverage lead to a choice between financial hardship and unmet need. People experience financial hardship when out-of-pocket payments are large in relation to their ability to pay. Out-of-pocket payments are formal and informal payments made at the time of using any healthcare good or service. Out-of-pocket payments may not be a barrier to access to care when they are small and paid by those who can afford them. But even small payments can cause financial hardship for poor households and regular users of healthcare. No one should experience financial hardship or unmet need. No one should have to choose between using health services and meeting other basic needs. So what is financial protection? Financial protection is the degree to which people are protected from out-of-pocket payments when using healthcare. It is a health system goal on its own right, highlighted in global and regional reports and commitments, including the Tallinn Charter, the 2010 World Health Report, and Health 2020. It is one of the priorities for health system strengthening in the European region, and it is an indicator for the Sustainable Development Goals. Financial protection is at the heart of universal coverage. There is no UHC without financial protection. We are filling a gap in evidence and relevance with this work. Previous analysis covering a large number of European countries relied on data from the 1990s. Last year, WHO and the World Bank published a new global report on UHC using the SDG metrics with results up to 2010. We have results up to 2016 for some of the countries we cover in this report. Equally important is that our report is using an advanced methodology and builds on context-specific, country-level analysis, which produces messages that are policy-relevant, action-oriented, and pro-poor. These advances were summarized in a comparative analysis of 3 high-income countries, the Czech Republic, Estonia, and Latvia, and they were recognized in the 2017 Global Report on UHC. Our results are now being used by the European Commission in the State of Health in the EU series, published jointly with the OECD and the European Observatory. The 2018 edition of the OECD's Health at a Glance report on Europe will also be using the results produced by WHO. We are very pleased to announce that the current issue of the WHO Bulletin, which focuses on SDGs, includes our research article on financial protection in Europe. The article sets out the equity and policy implications of the European methodology in comparison to other metrics. WHO headquarters organized a special event for the launch of this issue of the bulletin. So what did we know prior to this report? We knew that more public spending on health means lower burden on patients. So we argued for increasing the share of government expenditure on health. Our report confirms that financial protection is stronger where public spending on health is high. Based on earlier reports and global estimates, we could say that in countries where out-of-pocket expenditure is more than 15% of total spending on health, households face significantly higher risk of catastrophic and impoverishing levels of health expenditure and unmet need for services. In turn, our recommendation in the European region was to reduce and keep out-of-pocket spending below 15% of the total. The new evidence we present today suggests that in addition to reducing out-of-pocket expenditure, in general, it is equally important to have pro-poor coverage policies in place. An overall 15% at the country level may hide large variations across households. It may be too high for poor households and not a burden for others. Distribution matters. Our new regional report provides systematic data on distribution. As a result of this work, we know the answers to the three key questions of who experiences financial protection, what type of services drive financial hardship, which coverage policies work. We know the answers because the regional report is based on country-level analysis that goes beyond the numbers. Only the detailed, context-specific analysis can provide insights to the strengths and weaknesses of coverage policies and offer evidence-informed messages that are policy-relevant, action-oriented, and pro-poor. Before I hand over to my colleague, Sarah Thompson, who has been leading this work to present a summary of the findings, let me invite you to watch a short film about Lisa, who is facing a hard choice.
Can people afford to pay for healthcare? That's the central question that we are trying to address in our study. And when we talk about affordability, we mean for households, not for the health system, not for the government. When we talk about paying for healthcare, we are talking about any type of out-of-pocket payment, formal or informal, for covered care, for non-covered care, for care from public providers, and for care from private providers. When we talk about healthcare, we mean the full spectrum of health services, from prevention to palliative care. And when we ask whether people can afford to pay for healthcare, we are measuring the extent to which people are able to use health services without experiencing financial hardship. To answer the question, we're using two well-established indicators. Both use national sources of data, household budget surveys. And every country in Europe carries out these surveys at regular intervals. The surveys collect data on how much each household is spending on health through out-of-pocket payments. We can use the data from these surveys in two ways. First, to identify households with catastrophic out-of-pocket payments. These are households that spend more than 40% of their capacity to pay on healthcare. A household's capacity to pay is what is left from a household's budget after deducting a small amount to represent the cost of meeting basic needs, food, rent, and utilities like water, electricity, and housing. We can use the same data to identify households with impoverishing out-of-pocket payments, households who are above the poverty line before they pay for healthcare, but are pushed below it after paying out of pocket. And we also look at very poor households who are already living below the poverty line. If these households have to make out-of-pocket payments, we deem them to be further impoverished. So what do the numbers in our study tell us? First, the numbers tell us how many households are impoverished, the red bit of each column, the orange bit of each column, or further impoverished, the red bit of each column. As you would expect, the incidence of impoverishing out-of-pocket payments is generally higher in countries in the east of the region. But it's striking that even in Europe's richest countries, there are households who are impoverished because they have to use healthcare. The good news here is that efforts to reduce the financial hardship associated with out-of-pocket payments will also reduce poverty. The numbers tell us how many households experience catastrophic out-of-pocket payments. On the left, you see countries with stronger protection, where the incidence of catastrophic spending may be as low as 1% of households. On the right, you see countries with weaker protection, where the incidence goes up to 15% of households. There's a lot of variation across the region. Importantly, the numbers tell us who experiences catastrophic spending. This figure shows you the incidence of catastrophic spending broken down by income. The darkest part of each column is the poorest households. The lightest part of the column is the richest households. This figure paints a very clear picture. In every country, it is the poorest households who suffer the most. The numbers tell us which health services are responsible for catastrophic spending. This figure is a breakdown of catastrophic out-of-pocket payments by type of health service among all households. Across countries, we can see two clear pictures. On the left, among countries with stronger protection, you can see that dental care, in blue, is usually the main source of financial hardship. On the right, among countries with weaker protection, you can see that it's spending on medicines, shown in red, that really leads to financial hardship. If we focus on catastrophic spending among the poorest households, the picture changes. Now we see that medicines, outpatient medicines, are the main source of financial hardship across all countries, even in countries with stronger protection. And finally, the numbers confirm that financial protection is stronger where out-of-pocket payments are low. This figure plots catastrophic incidents on one axis and out-of-pocket payments as a share of total spending on health on the other. And you can see that there's a strong association between the two. But the out-of-pocket payment share doesn't explain everything. If you look at the 4 countries highlighted in red, all of them spend the same share out of pocket, around 24% of total spending on health. But they have very different levels of catastrophic incidents. And to find out why this is the case, we need to dig deeper. Coverage policy is a good place to start digging. Gaps in coverage expose people to out-of-pocket payments. Because gaps in coverage vary from one country to another, we need to look at them on a country-by-country basis. By linking numbers to policies at country level, we gain a better understanding of what it is that causes financial hardship in each country. So looking at policies in context gives us the story behind the numbers. Population coverage is the first story. Being covered is really fundamental. Without it, there isn't any protection. But it's not enough to guarantee protection. The countries shown in the darker blue cover the whole population, and most of them have a very low incidence of catastrophic spending. In contrast, the countries shown in light blue do not cover the whole population, and catastrophic incidence is generally higher. There are at least 2 reasons for the difference in population coverage across these countries. First, some of the dark blue countries base entitlement on residence, but the countries on the light blue side may not. Second, some countries on both sides base entitlement to healthcare on employment or on payment of health insurance contributions. But countries on the light blue side may lack effective mechanisms to actually enforce participation. This is really a tax collection problem, and it's worth asking why it is that the health system should punish people for the failures of the tax system. But going back to the darker blue side, if a country covers the whole population and still has a very high incidence of catastrophic spending, we know that we need to look at other dimensions of coverage, like service coverage. Gaps in service coverage have different effects on the rich and on the poor. They often lead to financial hardship for the rich and unmet need for the poor. In European health systems, 2 of the most common gaps in service coverage are dental care and outpatient medicines, even in high-income countries. This figure shows you the breakdown of catastrophic out-of-pocket payments in Lithuania, where dental care is not covered for adults. The breakdown is by quintile, with the poorest households on the left and the richest households on the right. Everyone in Lithuania is using outpatient medicines, shown in red, and medicines are a major source of financial hardship for all except the richest households. Dental care, on the other hand, is not a source of financial hardship for poorer people, even though it isn't covered for adults. And this is because poorer people just aren't using dental care. In Lithuania, unmet need for dental care is 8 or 9 times higher among the poorest households than among the richest households. I've highlighted the example of Lithuania today, but it's not the only country in which we see this pattern. We see this pattern in many countries in the region. And it tells us that when it comes to monitoring financial protection, unmet need has to be part of the analysis because it is often part of the story. The third dimension of coverage is user charges or co-payments. Here is our friend from the film, Lisa. Lisa has to pay for medicines to treat her diabetes and her heart disease. Many countries in Europe do not make people pay for primary care because they want primary care to be accessible to everyone. Yet almost every country in Europe makes people pay for medicines, even though medicines are an essential part of treatment in primary care. We know that co-payments for outpatient medicines often lead to financial hardship in Europe, but our study shows how countries can avoid this by carefully redesigning co-payment policy. Strong co-payment design has three features: exemptions, caps, and using low fixed co-payments. These three design features protect people against failures in the health system, against system waste and system inefficiencies. In contrast, weak co-payment design, no exemptions, no caps, the use of percentage co-payments, means that people pay for system failures. I'm briefly going to go through these three design features, and then I'll conclude my talk. First, the type of co-payment makes a difference. With percentage co-payments, people have to pay a share of the service price, and this is really challenging when there is a lot of variation in prices, for example, with medicines. What we find for the high-income countries in our study is that the countries with the weakest protection are the ones that use percentage co-payments for medicines. Percentage co-payments are unfair when prices vary because people with conditions that require more expensive medicines have to pay more. Percentage co-payments also create financial uncertainty. Living in these countries, our friend Lisa does not always know how much she has to pay from one month to the next. And sometimes she has to pay more than she should because her doctor wants her to use branded medicines, even when good quality generic medicines are available. Many of the countries with strong protection use low fixed co-payments for medicines. That is, they charge the same rate for all prescribed medicines. So if Lisa lived in the countries with fixed co-payments, some of her problems would disappear. She would know exactly how much her regular treatment costs, and if her doctor or her pharmacist insisted on branded medicines, she would not be the one paying the price for their inappropriate advice. The second design feature is exemptions. In countries where financial protection is weak, protection against co-payments is also weak. Lisa lives on a very low state pension. But in these countries, she has to pay for her medicines because there are no exemptions for poor people and no exemptions for people with chronic conditions. In the countries with stronger protection, Lisa would not have to pay because poor people are often exempt from co-payment. And if Lisa lived in the United Kingdom, she would be exempt even if she weren't poor because she's over 60 and because she has a chronic condition. The third and last design feature is caps on co-payments. While exemptions provide targeted protection, caps will protect everybody if they're carefully designed. Some of the countries with stronger protection actually link the cap to income. And in these countries, this gives Lisa the security of knowing that she will never have to pay more than 1 or 2% of her income on healthcare. The countries in our study show how carefully redesigning co-payment policy can have a huge impact on financial protection. The countries provide good evidence in support of these three clear steps to reducing financial hardship. They also suggest that co-payment design should be simple. It should really focus on what is likely to work best from the perspective of the people using health services. In summary, our analysis shows consistent patterns across countries. The numbers tell us to protect poor people and improve coverage of outpatient medicines. The stories behind the numbers help us to identify gaps in coverage and also ways of filling these gaps. There is a wealth of good practice in Europe, and I've really just covered the tip of the iceberg here. Many of the stories that we'd like to tell will be in our regional report. But the good practice is not yet widely applied, and yet the evidence and the examples are there. A closing thought. Improving financial protection requires numbers and stories. It probably also requires learning from others. But most of all, it requires putting people first. So when we're thinking about what could be done, we should make sure that we're thinking about people like Lisa. Thank you.
Thank you. Thank you for very interesting presentations. Health financing is most important issue, and we are very much respect to Barcelona office. But my request could be in future, maybe that's too little squeeze the presentations to leave more time to member states for the discussion. Okay. Thank you. And before we move to this member states, I would like to ask Professor Charles Norman to provide some reflections. Please.
Thank you very much, and thank you for inviting me to say a few words here. This, I think, is one of the most important studies that has been done in recent years in this area, because what it does is help us move from conjecture to some real evidence around how you can design better ways of protecting poor people from either unmet need or catastrophic payments. And I want just to emphasize in this both of these features, and I'll come back to this in a moment. The only thing that disappoints me about this study is that I can't find a way of claiming very much credit for it. I would like people to think it was entirely my inspiration that caused all this good work to be done, but I had only a small part in advising and thinking about these issues. But what it's doing here is putting some flesh on the bones of the question of universal coverage and the questions around user fees and co-payments. Those of you who enjoyed listening to me in Tallinn, and perhaps the rest of you as well, will know that I never use the term cost sharing, because cost sharing is nice and cozy, it's nice, it's pleasant, it's helpful. I use co-payments or user charges because that's the reality we're talking about here. I've only changed slightly today, though in honor of my great friend from Austria, I'm going to always say excessive before every time I say user charges. So if I forget, Clemens, if you'd like to put your hand up just to remind me. But I come back to universal coverage is about giving access to everything that works, everything that's good value. It isn't about giving access to everything, it's about giving access to everything that is appropriate in the context of the country. I think we have to be clear about that, because a lot of the mistakes made come from the fact that people promise more than they can achieve, and they end up, therefore, having very high user charges that are part of the mechanism for paying for the unaffordable level of service. So we're not talking about everything, we're talking about everything we ought to do. That really gets us down then to the dilemma, and the slides I think earlier on showed this very powerfully. We have the dilemma, you either put people off using the service, so they're not impoverished, but they are impoverished in terms of their health, or you don't put them off, and they are impoverished financially, even if they get the treatment. And I think the great value in this study is it's given us detail to understand this better. And I want to give one example from Ireland, because there was a nice piece of innocence in the time of the early part of the financial crisis when user fees were introduced for prescription drugs, even for the poorest people in the population. And the data were really quite encouraging. They suggested the amount of reduction in use of drugs was quite small. until you looked at it carefully. When you looked at it carefully, the people who stopped using the drugs were the poorest part of the population, and the drugs people stopped using were the important ones that didn't make them feel better. So, for example, people stopped using drugs that lowered their blood pressure. I don't know if any of you have had high blood pressure, but high blood pressure, as we know, is great. It feels great. Unfortunately, it kills you. Low blood pressure feels terrible, but you live. That's the dilemma we face. The drugs that people stopped taking were the ones that didn't make you feel good. There was a big drop in the prescriptions that were filled for antidepressants, but not for anti-anxiety drugs, because anti-anxiety drugs make you feel better. Antidepressants make you often feel worse in the short run, even though they may be very effective in managing the underlying condition. I give this example because it gives an instance of how these kinds of fees can be impoverishing if they're badly designed, and they can lead to unintended consequences in terms of putting people off the use of services and leading to unmet needs, which can have very, very negative consequences. So let's think a little bit about each of these things. And what have we learned from this study about how best to design both exemptions and the design of user fee structures? Now, those of you who know me will know that I think user fees are fundamentally about only one thing, that is money. They are only about raising money. If anyone wants to have an argument with me, they're going to lose it if they try, but if anyone wants to have an argument with me, they do not lead to better decisions about what services to use. The idea that you use user fees to try and guide people through the system is a myth. In case anyone didn't get that, the use of user fees to guide people through the system in a better way is a myth. It doesn't work. It puts people off both the useful and the useless in similar proportions. It does, of course, reduce utilization, because if you put up the price of anything, people will use less, but they will use less of both the useful and the less useful things. User fees will be with us probably forever, and in some countries they'll certainly be with us forever, because we will always have a need to raise funds, and taxation and social insurance systems will always be a bit limited in how much people are willing to have raised through those mechanisms. I'm not saying we will ever be without user fees. What I'm saying is the purpose of user fees is simply to raise money. Therefore, we must design them in ways that raise that money, doing the least possible harm. And what Sarah's presentation and Tamash's presentations have shown us is that we can actually design good user fee structures. I'm glad to say I am not at high risk of being impoverished because I have the great advantage of a huge salary, a huge pension. No, it's not true, actually. I just thought I would see if anyone was awake. But people like myself don't have serious worries about moderate, non-excessive levels of user fees. But we still may be discouraged from using certain services, and so we have to be a little careful in design. And this comes back, I think, to the most important point that comes out of this study. The devil is in the detail. There's no good saying user fees are harmful, user fees are harmless. You have to say exactly how do you design them to make them do the least harm and to raise the money needed to pay for the services. And we know that that is about keeping them generally low and particularly ensuring they're low for people on moderate or low to moderate incomes. We know that keeping them affordable helps a lot, but the design of them in terms of being fixed levels rather than percentage levels makes a huge difference. Otherwise, you penalize those people who choose to have expensive illnesses, and you reward people who choose cheap ones. Now, people don't always actually make a deliberate choice. They sometimes get sick because they get sick, and we shouldn't be penalizing people on the basis of which illness they have. Similarly, we want them to be capped so that no one will find that the accumulation of lots of things wrong with them is going to be the cause of impoverishment, not because they have one disease, but because they have lots. And we know that exemptions for the poor and people who are in high need are typically a very useful part of that design. So we actually kind of know how to do it. And the great thing is we now have evidence from lots of different countries that will allow us a much more sophisticated way of doing this design. We know that we want to try and avoid the total level of user fee in the system because, as Tamash's data showed, if you keep user fees below about 15%, it's much easier to avoid some of the more catastrophic consequences that come out. So we don't want them to be overall too high. We want them to be designed to be pro-poor. They should be fixed rather than percentage. They should have appropriate exemptions for those people who otherwise would be adversely affected. And actually, we now kind of know how to do it. So any country that's not doing it this way, get yourselves sorted out, because we actually now have enough evidence to design them better. And we can move towards a situation where the user fees, the non-excessive user fees that we need to have, can nevertheless be structured in an appropriate way. So it's been a privilege to be slightly involved with this study. I'm very impressed with what we now know, and I think we really can now take practical steps based on this evidence to make things work a whole lot better than they have done in the past. Thank you very much for your attention.
Thank you very much for a very interesting presentation as well as a first reflection. And now we are moving to the general discussion, and I'd like to ask member states who wants to have an intervention to raise the... We will start with Austria, please.
Lithuania.
Followed by Lithuania.
Belgium.
Thank you very much, Chair. Susanna, we have to thank you that you grant the freedom to Tamas and Saras to do this groundbreaking work. Really, this is, and as Charles already said, this is groundbreaking work. It's a new method, wonderful results. And as a representative of a high-income country, I just repeat what I also have said at the Tallinn conference. You know, we also have to admit that even in a high-income country, there are leasers. We have to know that there are leasers who cannot afford paying for co-payments. So even if we have, and Sarah's slide showed it, we have a very balanced systems of co-payments. You know, we have exemptions, we have protective caps, we have also a relatively low fixed percent as a co-payment percentage. By the way, it's all digitally controlled. So we use digital services there. But, you know, still there is a reality that some people in the country cannot afford this kind of co-payments. And we're doing fairly well with medicines. But Austria is not doing a good job when it comes to medical aid. So there is, and this is, I think, the lesson what we can learn out of these studies, a constant need to adjustment. And this is a call on us, on people like me, on people, many of people in this room, that we have to look carefully if we have these kinds of systems, because we have to adjust them to the reality, to the real needs of the people, of the citizens. So I would once again thank you for this groundbreaking work, and I'm very pleased, and it should be a cookbook, how to design our services in our member states. Thank you very much.
Thank you, Austria. Lithuania, please, followed by Malta.
Thank you, President. And first, I would like to thank for the very wonderful presentations. And I must say that Lithuania truly welcomes the WHO Regional Office for Europe initiative to support member states with monitoring financial protections, producing country-level analysis for national policy developments in the context of SDGs, and providing policy recommendations in the field of financial protection and universal health coverage. It was already very instrumental for Lithuania. One of the goals of the ministries of health in all countries is to ensure that everyone can use high-quality health services they need without experiencing financial hardship. Lack of financial protection can lead to a range of negative health and economic consequences, reducing access to health care. undermining health status, deepening poverty, and exacerbating health and socioeconomic inequalities. Even small out-of-pocket payments can cause financial hardship for poor households and those who have to pay for long-term treatment. Therefore, Lithuania supports that monitoring of financial protection that is a core component of health system performance assessment. Lithuanian case study revealed that there is a room for improvement, notwithstanding that the compulsory health insurance based on compulsory insurance contributions and transfers from the state budget provides universal health coverage, healthcare coverage to all residents of Lithuania. The high out-of-pocket payments, mostly on pharmaceutical products, account for 32% of total spending on health, and the public spending on health is relatively low. High out-of-pocket expenditure on medicines is the most important cause of financial hardship in Lithuania. I would like to share with you information about the reforms recently initiated by the Lithuanian government to assure the universal health coverage and better access to healthcare. Seeking to reduce the level of out-of-pocket payments and improve the accessibility and affordability of medicines, Lithuania recently adopted pharmaceutical policy, which foresees several measures in this field, including uniform 5% VAT rate for all prescribed medicines, the maximum patient co-payment, promotion of reasonable consumption of generics and biosimilars, tightened conditions for the inclusion of medicines into positive list, and many others. The government of Lithuania is determined to further work in these directions in order to provide the high-quality health services without experiencing financial hardship. Thank you.
Thank you, Lithuania. Malta, please, followed by Belgium.
Thank you, Mr. Chair, Mr. President, Regional Director, distinguished delegates. We have recognized that health and wealth are intrinsically entwined for a long time. At the same time, financial protection is central to universal health coverage and the core dimension of health system provision and quality. 10 years ago, we adopted the Tallinn Charter, stating that it is unacceptable that people become poor as a result of ill health. Today, even more so, this statement holds true, and likewise, it is also unacceptable that people develop ill health as a result of poverty. Policies directed at breaking the link between ill health and poverty are therefore essential to address the strengthening of equity, solidarity, and financial protection and curb this cycle of deprivation. Our healthcare system is founded on the principles of equity and solidarity, and it offers a comprehensive package of healthcare services to entitled individuals free at the point of use, with means testing for some elective services. The system also provides coverage for vulnerable groups such as irregular migrants. The private sector complements the tax-funded public health services, particularly in primary care. Out-of-pocket payments amount to 94% of the 30% or so of healthcare expenditure that is privately funded. Yet, data from the Survey on Income and Living Conditions show Malta to have one of the lowest rates of unmet need for medical care. In the DG's address yesterday, he highlighted the divides observed within our region, also evident within countries and between citizens and migrants. We recognize that achieving the SDGs and UHC within the triple billion goals cannot be done without addressing the many social determinants of health. And for this reason, we have embarked on a major project to establish a national platform to address the social determinants of health. WHO's evidence now confirms even more that health payments are unaffordable for many, causing financial hardship across our region. More than ever, we need to focus on working towards achieving and maintaining the sustainability of health systems to be able to continue to provide high-quality and efficient healthcare services that also elicit value for money for both the provider and the patient within one's ability to pay for healthcare. We believe that innovation is key in all aspects: innovative funding mechanisms, public-private partnerships, service provision and prevention services.
Targeting the social determinants of health through improving health literacy and working towards providing access to those hardest to reach is imperative to further reduce inequalities. Cooperation on price negotiations with regard to pricing of medicines, such as is happening within the Valletta Group, is a promising way forward in jointly addressing the exorbitantly high prices of innovative medicines. As a country on the front line of migration issues, Malta also recognized the related serious challenges that accompany migrant movements, primarily for the individuals themselves, but also the impact on the local healthcare services. Such humanitarian issues must remain high on the agenda in a bid to ensure that healthcare is affordable to all. Thank you.
Thank you. Belgium, please, followed by Netherlands.
Thank you, Mr. Executive President. Let me go back to the WHO Oslo conference in 2013 on health system and the economic crisis, organized together with the European Observatory. At that time, we discussed how many European member states suddenly had to cut health budgets as a consequence of the economic crisis. Too often, this was done short-sightedly, through measures that affected the most vulnerable more heavily and through savings on public health programs, understand preventive programs. However, we also have to admit, too easily, we have put the blame on others for the unwise choices. Indeed, as health minister, we were not prepared for this. We didn't always possess the necessary evidence, and had to negotiate about and defend essential investment in health. This was our responsibility. For example, we had to admit that our monitoring of access to healthcare was rather poor. Evidence was patchy and often subjective. Despite the important budgets we invest in health insurance, we didn't really know how access to healthcare was evolving. Fortunately, since 2013, things have changed, also thanks to WHO. Hence, we would like to congratulate WHO for its initiative to monitor financial accessibility. This work is conceptually clear, methodologically strong, and has actionable outcomes for policymakers. Today, we are happy to announce that also Belgium is ready to join this initiative. To conclude, a short word of caution. As health ministries, we shouldn't take a too narrow perspective on access to healthcare only. I am thinking, for example, of long-term care. Long-term care might drive impoverishment even more than the need for acute healthcare due to, by definition, its long-term nature and loss of income. Hence, we believe we need a holistic vision on social protection, not limited to healthcare only. I thank you for your attention.
Thank you. Netherlands, please.
Yeah, Mr. President, first of all, congratulations on the very interesting presentations we just heard. WHO Barcelona office has committed an interesting and rigorous analysis of the number of people that bear financial hardship as a result of limited financial protection. The added value seems to lay in the use of metrics, such as the number of people that fall below poverty lines because of health spending and the use of anonymized microdata for household budget surveys. And the Netherlands compliments and thanks Europe for this analysis. Two important findings of this study are the impact of co-payments on pharmaceuticals and of limitations in dental care coverage, leading to excessive out-of-pocket payments. In the Netherlands, co-payments are not widely used for pharmaceutical care, and also dental care is well covered, with citizens up to 18 years of age having free access to dental care, and adult people are for 70% covered on a voluntary basis for dental care. Dutch user charges, I must use the term user charges, I heard, very much come down to 385 euros deductible, with exemptions for primary care, children and low-income groups. And this works essentially as a limitation on user charges, and in this way resembles the study findings as has been shown in the report. It might very well explain why the Netherlands stand out well in this analysis. If adequately designed, a maximum deductible with certain exemptions and few or maybe no co-payments might form an alternative for financial protection. Once more, we would like to thank WO for this study, and we would be happy to share our experiences in further elaborations. Thank you.
Thank you. There are no more requests from the member states, and with your permission, I will move to the non-state actors. We have a request from the two groups of the non-state actors. First is joint statement from the International Federation of Medical Students Associations, European Medical Students Association, European Forum for Primary Care, Studiorum. Please.
Honorable Chair, distinguished delegates, the IFMSA, EMSA, European of Primary Care and Studiorum congratulate the regional office and the member states on their work ensuring financial protection. We acknowledge that health system monitoring is essential to support evidence-based decisions and effective policy responses. Despite improvement in healthcare services, inequities in health still remain. As pointed out by the regional study, in Europe, a significant percentage of the population is pushed beyond the poverty line by out-of-pocket payments. Additionally, the increasing price of essential medicine is one of the major challenges faced by health systems worldwide. We strongly encourage open discussions between nations, medical companies, and patient groups, as we believe they are required to bridge the financial gap. We would like to emphasize that reforms in the financing policies, such as increased but also more efficient and equitable governmental funding, are required to achieve financial protection. Also, we would like to highlight that changes in the health system, taking all the 6 building blocks of a health system as described by the WHO in regard, will bring us closer to achieving universal health coverage. We would like to point out that health systems do not only serve to treat and prevent illnesses, but are also functioning as effective means to a country's economy. Moreover, healthy adults are more productive, and healthy children perform better in school. This improves economic performance and enables economic growth to be sustainable and inclusive. Therefore, we urge upon governments to ensure financial protections for all its citizens by increasing government spending as a fraction of total hand expenditure, keeping out-of-pocket payments for healthcare at a minimum, and facilitate transparent, equitable, and efficient financial management systems. Thank you.
Thank you. The next statement we have from the Public Service International.
Mr. President, thank you for giving the floor to the global and European trade union organizations, federations that represent and organize the health workforce. Public Service International and the European Public Service Union agree with the perspective expounded in the working document for the agenda item that financial protection, particularly for the poor, is necessary for universal health care to be a reality. PSI and EPSU also fully share the view expressed in this document that ensuring high levels of public spending on health plays a vital role in reducing out-of-pocket payment, but coverage policies are also important. This, for us, implies a commitment of governments to strengthen healthcare systems built on mechanisms of financial solidarity that are based either on tax income or on social contributions from statutory social protection systems, be it national health systems or health insurance-based systems, but that are also committed to the realization of a general interest orientation of health services. As coverage policy is the primary mechanism through which households are exposed, or not or less, to out-of-pocket payments, for EPSU and PSI, this implies that healthcare systems and policies should aim at eligibility criteria for healthcare that cover the whole population. The entitlement condition to specific benefits or services should also include provisions on user charges to minimize co-payments in general, and in addition, contain mechanisms with an additional protection for people below certain income threshold. We also share the call for more public investment in health systems. For us to ensure a skills mix and competencies fit for the future, and integrated service delivery models centered around the patient users. However, equal weight should also be given to the needs of the health and the care workforce delivering them. In a time of staff shortages, increasing incidence of work overload, high work intensity and burnout, only such funding and investment can help guarantee effective recruitment retention conditions. For PSI and EPSU, this is also a precondition to keep healthcare sector an attractive sector for employment, to support ethical cross-country recruitment, and to have adequately staffed health services. To conclude, if a people-centered paradigm and a human rights approach is consistently upheld, with commitment to universal health care, financial protection would be a given, and the question of people's ability to pay for health care, including for vulnerable groups or poorer citizens, would be a moot one, particularly in the European region. We are looking forward, EPSU and PSI, for cooperation with the WHO on all issues related to the health workforce and to healthcare system reform. Thank you for your attention.
Thank you very much. I would like to ask Dr. Evetovic or Dr. Kluge to respond, and please sure that already 6 o'clock and the interpreters will have to save time for interpreters.
Thank you, Chair. For the sake of time, I leave it to Hans to respond.
Thank you, everyone, for the very positive comments you gave. I must say that indeed, as a director, I'm very, very proud of this work as well, but proud of the collaboration, because it took a lot of transparency from the side of the member states to do this work together so that we had real data to act upon. And it shows, once again, if there's sound evidence, trust and political commitment, that good policies can really protect people from poverty, and good policies, in fact, reduce inequalities. I think the next steps are the stage 2 of the work, which will be helping countries which have asked to implement the actual policy recommendations. And His Excellency, the Minister of Health of Lithuania, was already mentioning the 3 Ministers of Health of the Baltic countries decided to have the Baltic policy dialogue on this matter together with the European Observatory, and many more countries. In fact, I see the Deputy Executive President looking. Greece, for example, has now also taken the blunt decision to provide dental care free of charge for children recently, and to abolish a co-payment for medicines, and many more member states. So this is excellent news, and our further collaboration with the EU, the European Commission, and the OECD on this will also continue. Thank you so much.
Thank you very much. We are to the end of our discussion for today. This very, very interesting and very important issue. Once again, thanks to presenters, thanks to member states, to non-governmental organizations, to interesting discussion. I have only 3 announcements. The first one is that the first one is that we would like to inform you that before the plenary tomorrow, breakfast meeting, 8 o'clock takes place in the Pininfarina Hall, and the title of the meeting is Countries at this Center. Everything you always wanted to know about WHO country work. Anyone interested in hearing more from the WHO representatives is welcome to attend. Second announcement is that tomorrow, 9 o'clock, the plenary will start with the item of immunization action plan. What we stopped today, as you remember, was quite a long list of the member states wish to have an intervention, and we will start with this intervention tomorrow morning, 9 o'clock. And then third, most important, that today Regional Director invites us to the reception, which starts 7:30 p.m. in Palazzo Brancaccio. Buses will leave immediately after this session to the hotels and then shortly to the venue. After the reception, the buses will bring you back to your hotels. Please leave your headphones in the room, and I wish you good evening. Thank you.
Thank you, Mr. President. Thank you.